We're going to go over multiple sclerosis and the concepts of mobility and immunity. This particular disease kind of falls into both mobility and immunity because it is an autoimmune disorder, but it's an autoimmune disorder that affects the nervous system, which then affects the musculoskeletal system and how they all function. Actually, in your Pearson book, this exemplar falls under the mobility chapter, so that's where you'll find that. So this disease is an autoimmune disorder where the body begins to attack the myelin sheath that cover the axons and the axons themselves. So the axons and the myelin, they break down and they scar. The myelin can be replaced, but the axons can't. So I kind of think of this as like an electrical cord that's been gnawed on and chewed on a little bit. So the signals may be coming through, but it's not coming through the way that it should, or maybe not coming through at all. So over time it can become worse. So we're going to talk about the different types that we may see, the different types of MS. On an MRI, this will look like a lot of scarring, and you may see lesions on the brain and on the spinal cord. So these are the different classifications. The most common type that you'll see is the relapsing remitting. That's at about 85% of the diagnoses of MS are that type, where somebody will have a flare-up followed by a period of remission where they don't have symptoms. Primary progressive is a slowly progressing type of MS, so the symptoms just progressively get worse and worse over time. Secondary progressive, this doesn't make up very many of the diagnosis of MS. That is where there's initially a relapsing remitting, but eventually over time becomes that primary progressive. So they go into periods of remission, but over time they get into where they don't have periods of remission anymore, and they just slowly, progressively get worse. Progressive relapsing is the progressive disease, so the symptoms aren't going away. They're slowly getting worse over time, but intermittently they will have periods of rapid worsening. So it's almost like a relapse on top of the disease that you already have. There are some risk factors. So females are 2 times more likely to develop this. Diagnosis is usually between the ages of 20 and 40. People with a European background, ethnicity, are more likely to have this, and smoking increases the risk of developing this too, just like almost every other autoimmune disorder that we've talked about. There are a lot of symptoms that are associated with MS, so you know I'm going to refer you back to the little person in the Pearson book, and that's on page 938. It goes over all the multi-system effects of MS. You'll see most of them have to do with the musculoskeletal system, so trouble walking, numbness and tingling in the hands, speech and swallowing difficulties, muscle spasms. Eventually some of this may lead to paralysis of the muscles and muscle wasting. Some of the other big ones are depression. Over 50% you see of people with MS suffer from depression. And also emotional lability, which means they may have periods of happiness followed by periods of depression. So they're kind of just flipping all over the place. Fatigue, that's with just about every autoimmune disorder, and most people with MS will complain of fatigue. Sexual dysfunctions can be a problem because there's vaginal dryness and pain for females. And then just erectile dysfunction with males. And then also the bowel and bladder dysfunction also is a major side effect. They may even become incontinent over time, which leads to its own set of problems. Then we may have vision problems and hearing problems. So really it affects the entire body. So make sure you go into your Pearson book and take a look at that little person. So when we do lab work, we're not going to really see a whole lot. We may just do this to rule out anything else that it could be. An MRI is going to show us those lesions and scarring on the spinal cord and on the brain. We may do a lumbar puncture to take a look at the cerebrospinal fluid. Some things that we may see in there is an increase in immunoglobulins, and we may also see some myelin breakdown in that cerebrospinal fluid. So treatment involves a lot of medications, and these are new, a lot of these to you, so I know you're excited about looking at a lot of new medications. So they may get beta interferons that decrease inflammation, that glatiramer acetate, that it blocks the immune response on the myelin, the fingolimod, and usually the nurses, they use the brand names, but we want you guys to know the generic names, which are very difficult to pronounce. So the fingolimod, that traps immune cells in lymph tissue. Natalizumab stops the immune cell movement, so it kind of puts them in limbo. So all of these kind of work similarly to prevent those immune cells from breaking down that myelin sheath. Muscle relaxants are for those muscle spasms to prevent that from occurring. The main one we give for that is baclofen. We may give pain medication, and a lot of times we're given that gabapentin because it works really well for nerve pain. We give corticosteroids for the relapses, and it sometimes is in very high doses, so we've talked about all of the side effects that can occur when we give corticosteroids. Since depression is so common in these patients, we'll often give them antidepressants. May also give immunosuppressants, which, they're already at risk for infection because of everything else that this disease does to them. So now we're also suppressing the immune system. So think about the things that you need to do for somebody who's at risk for infection. We've talked about that a lot of times this semester. And we're also going to involve physical therapy, occupational therapy, and speech therapy in their plan of care. So there are a lot of complications with MS as well. Quadriplegia is a worry for them, and as they just become more and more weak over time. Life expectancy for just MS itself is not necessarily shorter, but because of these complications, their life expectancy may be cut short. They may develop pressure ulcers over time. They may develop osteoporosis, as that's a risk factor for all those high-dose steroids that they may be on. As they have difficulty swallowing, they may develop an aspiration pneumonia. Because of that incontinence, they could develop a UTI. Of course, the back and hip pain, the muscle atrophy, fractures, and again, depression is a big concern for them. So please make sure you're doing your reading and all the pre-work that you see in your course, and I'll see you guys in class.